welcome to the Preemie Chat, and thank you so much for joining us here today. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation, or CPBF. We are a charitable organization. Our mission is to empower families of premature babies through support and education. This Preemie Chat series is one of the many initiatives we have to bring information for NICU families and healthcare professionals. Here, every Friday, we talk with experts, researchers, and parents who share with us the experience and knowledge. Also, on our website, canadianpreemies.org, parents will find all kinds of resources and support. For example, this week we are just launched our new infographic on retinopathy prematurity. I'm going to share here with you. And to mark the Vision Health Month, you can download this infographic from our website, and I will share the link on the comments. And I want to thank our sponsors, AstraZeneca and Natus, for the ongoing support of our educational program. And today, we are, as I mentioned, it is Vision Health Month, and we are going to talk about retinopathy of prematurity, or ROP, an eye disease that affects premature babies and leads to blindness. We have three amazing speakers here today. Dr. Tehrani, who is the lead clinician in the ROP service at the Hospital for Sick Children, and two parents sharing their stories after their babies got diagnosed with ROP. And our first guest is, let me bring her to the stream, Dr. Tehrani, who will describe the basics of the effects of eye development for babies that are born prematurely, what this means in terms of risks of development of ROP, how this disease is monitored for and diagnosed. In addition, she'll describe when treatment is indicated and how this timely treatment can be utilized to prevent blindness. Small babies, you still need to be monitored for eye and vision development as they get older to make sure once the most severe and acute form of ROP is resolved, vision development continues as near as normal as possible. She will also describe the need for regular eye exams to identify other problems that premature babies are at risk of, including amblyopia, refractive errors, and strabismus, to name a few. Dr. Tehrani is an assistant professor at the Department of Ophthalmology and Vision Sciences at the University of Toronto and fellowship director for the Pediatric Ophthalmology and Strabismus Fellowship and staff ophthalmologist at the Hospital for Sick Children. Her expertise is in both medical and surgical treatment of challenging and complex cases of pediatric cataracts and glaucoma. She has a specialist expertise in management of retinopathy of prematurity, a keen interest in introducing telemedicine in the assessment of ROP in the more remote regions of Ontario, and is the lead clinician in the ROP service. Dr. Tehrani, thank you so much for joining me here today.
It's my pleasure.
It's pretty amazing that I actually met you almost 10 years ago when my son was in the NICU at Mount Sinai Hospital, and not even a million years I saw one day I will be hosting you to tell us even more about ROP. So nice to have you here today.
Thank you very much. It's my privilege to look after so many children that have been born premature in this city and wider field in Ontario, and even from other provinces and other countries. So small babies seem to have big eye problems, and I'm going to talk to you about that. Let's see. Good. I think I can tell you that I've got no financial interests or relationships to disclose with this talk, but I will be talking about some off-label medications that we use for treatment of ROP. So what I want to, I'll just go over some slides because it's sort of PDF, so I'm going to try and not share all the slides with you, but I want to tell you that first of all, as a review of the anatomy of the eye, the retina is like the film inside the camera, and we use the camera as an analogy for the eye. The eye then has to send the information to the brain, and the optic nerve is the beginning of that wire that connects the eye to the vision detecting part of the brain. That is also the point where the blood vessels that nourish the retina enter the eye. And then the very central part of the retina is the macula. You may have heard about it in diseases like macular degeneration. That's the part of the retina we use for fine vision, for recognizing detail, for reading, writing. And the very center of that macula is called the fovea. It's the most sophisticated part of the retina. So let's look at what we see when you look at images. So this is the right eye, this is the left eye, and the retina looks kind of reddish in color. You see the beginning of that wire, the optic nerve. You can see the blood vessels that come through it. And this part, which is a little bit darker, is the macula with the very center of it, the fovea, which you use for your very fine vision. Okay, so this is normal retina, and I will show this to you again later on. This disease, retinopathy prematurity, was first diagnosed in 1942. It only happens in preterm infants, and it happens because the normal growth of blood vessels in the retina stops. There are abnormal blood vessels that grow on the surface of the retina. So you can see in the corner here, there's the nerve with the blood vessels coming out of it, and you can see that there's a line. That's where the vessels have stopped growing. Now, fortunately, most babies get better without any treatment for this disease. I don't have to treat all of them. And even the ones who do develop ROP, the majority get better with treatment, and it's only very few that end up going blind if the disease is not detected in time and not treated in time. The risk for developing ROP is if you get additional oxygen, which a lot of premature babies have to get in order to survive and stay alive, if they're born very early, and if they're very light in weight. So low gestational age and low birth weight are risk factors. It's very appropriate. A week ago was the birthday of this man. You may recognize Stevie Wonder in his youngest self, and he was part of the first epidemic of ROP in the USA. And this is when it was recognized if you gave extra oxygen, you could keep babies alive, but then there were a lot more blind babies as a result. And then later on in the 90s, and there was a second epidemic because we were saving more infants, and these smaller infants were at a higher risk of developing ROP. These days, in the US data, we know that about 4 million babies are born every year. Almost 30,000 are born at the sort of weight that is in the high risk for developing ROP. Half of these babies will actually develop ROP. 90% or more will get better without treatment. About 1,500 will need treatment. And unfortunately, still a number will become legally blind. And I'll tell you why this may happen. So this disease was first diagnosed many years ago in Australia. The history tells us that these infants often have other problems as well. I'm going to talk to you a little bit about the pathophysiology of the disease, and I want you to look at these blood vessels in the back of the eye. This is an eye cut in half, if you like, and you can see that in the early stage of the disease, or the first phase of the disease, the small caliber vessels are lost and they are occluded. In the second phase of the disease, in the more severe stage of the disease, you've got abnormal new blood vessels forming. So you need to have new blood vessels form, but they also need to be normal. And this is what we're picking up when we do ROP screening. So let's look at the phases of the disease. And now we know that, in fact, reducing oxygen saturation to below 95% is helpful in preventing that first phase of the disease and preventing shutdown of existing normal vessels. In the second phase of the disease, where you get these abnormal new vessels developing, actually reducing the oxygen supply no longer appears to be helpful. So what do we do when we come across to sort of do the eye exam? We just use numbing eye drops, first of all, anesthetic drops, and the pupils are dilated. The eye doctor comes with a special ophthalmoscope on their head that looks like a hat. And then we have these instruments that are used for the examination. This looks a little bit like a paperclip because you need two hands, one for the lens that we use, the magnifying lens, and the other for the instrument that's used to rotate the eye or move the eye, you need something to hold the eyelids open, and that's the speculum. So often we tell parents they don't need to watch this because it's not particularly pleasant to see, but that is what it looks like when we're looking at the eye. What are we looking for? We're looking at the inside of the eye and the retina to look at how far the blood vessels have grown from the optic nerve in the middle. This is diagram showing you, and this is an actual picture of the eye. And we want to know if the vessels have only grown as far as zone 1, which is the more posterior part of the back of the eye. If the vessels are only in zone 1, then your baby has more severe disease. Once the vessels get into zone 2, the disease is a little bit less severe. And once they're in zone 3, which is in the very periphery, then often there's no indication for treatment. So this has not changed in the International Classification of ROP, which has been updated regularly. The zones are written in in Latin numerals, so that's how they're represented, and you'll see us refer to that. So we can go over that again if needs be. There are different stages of ROP as well, which are what I'm going to show you some images of, and I will skip through some of them very quickly, but look at this. This is the nerve, the blood vessels, and you can see where the vessels come to a stop, and you can just barely see a line. That's stage 1. We usually don't have to treat this stage unless it's in zone 1 with plus disease. When that line gets a bit thicker that you can see here, we call it stage 2. And then later on, you can also see, again, stage 2, but there's some other things developing behind that stage 2. These are new little bunches of vessels growing. We call these popcorns to begin with because they look like popcorns. These popcorns can join together. You can see that's where the vessels stop, and you can see that they actually hide the blood vessels underneath. That's what confluent popcorn looks like. As things get worse, you can actually get abnormal blood vessels that you can see more on these pictures. And again, in fact, more easy to see here, where you've got a band of abnormal blood vessels hiding the blood vessels underneath. And that's where the vessels have come to a stop. This is stage 3, and this is a time where definitely the baby will likely need treatment if there is something called plus disease. So this is stage 3 when it's shown with dye test. So sometimes we put an injection of a dye into the blood vessels to actually show us in black and white where the blood vessels are. And these areas where the dye has leaked out shows you stage 3. Okay, you see how now this looks a bit like popcorns in the eye. Again, showing stage 3, showing these areas of abnormal vessels, and these white marks are actually fresh laser marks. So we also talk about something called plus disease, and these are blood vessels that look like corkscrews. So if you look at this, which was the picture I showed you originally, and these normal vessels, you can see there's a clear difference between this one and the one below here. And the reason is that now you have very abnormally dilated vessels that are wider than normal and vessels that look like corkscrew. Okay, and this is what plus disease looks like. So most people will be able to recognize there's a progression from here to here, and the blood vessels at the back of the eye have changed considerably. Sometimes you also see abnormal blood vessels at the level of the iris, at the pupil. So this is a side view. This is the iris, the colored part of the eye. This is the pupil. Behind this is the lens. And you can see these abnormal network of blood vessels. If you were going to see this, that would be something that you could see naked eye with a magnifying lens without that hat on our head. So that, again, is something that develops when you have severe disease. These are later stages, stage 4, where the actual central part of the vision has become affected, and this is stage 5. At this point, game's over. If we wait until we've got here, we cannot save your child's eyesight. You need surgery at this stage, and you'll have very poor vision recovery. So the aim is to get things before we get to that late stage. So let's move on and to see what we do. So we want to do screening eye exams before treatment is needed, and we want to be able to identify what's called type 1 disease. And the best time to do the eye exam is to wait at least 4 weeks, because it takes some time for ROP to develop. There's no point doing examinations immediately when your baby is born. Nothing is there to be seen. And we need to examine those babies who are at high risk. So those that are less than 1250 grams or less than 31 weeks of gestation when they're born. And this is indications for treatment. We know that if you've got blood vessels have gone into as zone 3, there's almost never an indication for treatment, and stage 4 and 5 would need surgery. So if your baby needs treatment, you fall into one of these two categories, either in zone 1 or zone 2, and your doctor should be able to go through those stages with you and describe them to you. What are the options for treatment? So historically, we used to be able to freeze that peripheral part of retina that didn't have blood vessels in it. We call that avascular retina. As time moved on in the 1990s, we were able to apply that treatment more accurately and more precisely with laser. And so this is in fact me giving laser treatment in the 1990s. And then in the 2000s, in the mid-2000s, we started using medication that is used for macular degeneration in adults for treatment of ROP, because there are some similarities in how the disease develops. So there's several medications that have been used. Many of these have actually have been studied in large-scale studies, but we still don't have all the long-term data for any of these medications. So you will recognize some of these medicines that are being used. These are the generic names, and on the right-hand side, I've got the trade names that are shorter and easier to pronounce. So what are the treatment choices for retinopathy of prematurity? So let's tell you why we even go to thinking about using anti-VEGF medication that we use as an injection inside the eye. And I think these pictures will speak a lot of words for us here. So this is the same eye. Look at the nerve, look at the blood vessels, and the arrows show the same place in the two images. So this is earlier on, and this is a few months later. This is where the blood vessels had stopped, just next to where the blue arrow is, at the time that this baby received an injection for treatment. Look at all the extra area that the retina has developed and has got blood vessels in it. You can see those blood vessels with the help of the dye test. So that's the big advantage of giving an injection. If I had treated this baby with laser, I would have had to treat all of this area. So all of this area from here to the left of the picture would have been completely destroyed. The blood vessels, even if they grew, they would have grown into retina that was like a desert. It does not function. So this is the reason why anti-VEGF medications are useful, because they allow treating the disease without destroying that peripheral retina. How is that good for us? Well, there are good points, there are bad points. I'm going to go through them with you. When you give laser treatment, it takes longer to do, and you have to use so many points of treatment, and it takes a lot of time, and you have to be able to apply it precisely. Therefore, you often need a general anesthetic, and the baby needs to be intubated. Anti-VEGF injections, you give as an injection. It takes a couple of seconds to put the needle in the eye. You do have to put a needle in the eye to deliver the medicine. You cannot do it with eye drops. So it's short. It can be done with a topical anesthetic with an eye drop, or at least a little bit of sedation in the IV. No general anesthetic is needed. Also, you can treat one eye at a time when you do an injection. If you have to put the baby to sleep, you often have to treat both eyes in the same sitting, because we don't want to treat one eye only to find that the other eye gets worse a few days or maybe a week or two later. So we end up treating both eyes more frequently. Laser treatment is irreversible retinal destruction, whereas injection allows the retinal blood vessels to grow. We also know that babies that have laser treatment are much more likely to need strong glasses prescriptions and become nearsighted. That risk is lower with injection. That field of vision, that area of retina that develop normal vessels, is much more likely to function. So you don't end up losing your peripheral field of vision as you do when you do laser treatment, when you give an injection. There is one downside, and that's a big downside. When you give laser, most of the time, a few weeks after laser treatment, once things have worked, you know that this disease is highly unlikely to reactivate. That's the case in our hands. If you give an injection, however, all you've done is zeroed the clock. As if your baby is born again, now it can actually start to develop ROP a second time. And that risk of reactivation of ROP can happen weeks or months after treatment. And that risk of infection, risk of reactivation are all of things that you have to consider. It takes much longer before we can confidently stop doing the eye exams, and we still don't have as much data in terms of long-term safety. So why do we have to keep doing eye exams so long after injection? It's because these retinal vessels can keep growing since the part of the retina without blood vessels is not destroyed. The retina is irreversibly destroyed with laser. And these are all the things I said already. The eye can develop ROP a second time. Now the baby gets older and bigger and it's fighting whenever we're doing these eye exams. And so it becomes more stressful for the baby and the parents. And it also becomes more difficult for us to see the retina in a moving, fighting baby. So we always tell you when we do an injection that we may need to do an examination under anesthetic some months down the line. If there's been nothing that seems abnormal, we still need to do an exam under anesthetic. But now at a date when the baby is much older and the risks to having a prolonged period of time where the tube has to be in the airway is much less. At usually 6 to 9 months after due date, we look at the growth of blood vessels with that special dye test, the fluorescein angiography. And if there's a large area of retina that still doesn't have normal vessel growth in it, at this point we laser that area because we want to prevent chances of ROP developing again. And also, we don't want to put your baby through repeated examinations, which are becoming impossible to do. What happens with these babies when they grow older? So we know that premature birth not only affects the back of the eye, it also prematurely slows the growth and normal development of the front of the eye. This is why premature babies are much more likely to become nearsighted. Nearsighted people know that they can't see distant objects unless they have glasses. Term babies grow differently, and when they're born, they're actually a little bit farsighted. And as they grow over the first few years of life, they develop normal eye growth, and they can then see both distance and near. So being nearsighted is part and parcel of prematurity, but it is more common if you develop severe ROP. We know that. What is the data that we have? We've talked about refractive errors, glasses for both myopia and something else called astigmatism, which is an abnormality of the curvature of the front of the eye. These can be corrected with glasses or contact lenses. Amblyopia, or a lazy eye, where one eye is weaker than the other eye. And if that's detected, then treatment often involves patching the stronger eye. These infants also can develop strabismus or misalignment of the eyes. So both eyes are moving, but the one eye is turned either inwards or outwards. They can also have something called nystagmus, which is jiggling or wobbling of the eyes. And all of these things that I've described to you can actually impact the ability of the two eyes to work together. And they can have reduced stereo acuity or poor three-dimensional vision. So being able to perceive depths may be affected. Unfortunately, as you've heard from other speakers before, the brain also gets affected. And sometimes the eyes look perfectly normal, but the brain can't integrate the information it gets from the eye. And that's how some of these infants become diagnosed as and registered as blind and have poor vision. And it's mostly because they've got cortical vision impairment, because we are actually able to stop ROP from causing blindness in the great majority of our infants. We haven't yet figured out how to deal with that cortical part of vision impairment yet. If you look at infants that are born at term versus babies that are born preterm, and this is the number of infants they compared, you can see that the need for glasses is probably about 3 times as likely. The possibility of developing strabismus or misalignment is almost 10 times likely, and reduced stereo or 3-dimensional vision is about 3 times for babies that are born premature. Studies from treatment has shown us that a large number of these infants become nearsighted. This is after laser treatment, and strabismus about 30% at about 9 months. Now, you know that babies, when they're very in the first few months of life, are learning how to use their eyes together. So momentarily deviating the eyes or misaligning the eyes for a few seconds or a few minutes, not important. That's normal. I'm talking about misalignment that persists. So it's there all the time. And if that happens and it persists beyond the age of 6 months, it's definitely abnormal, and which is one of the reasons why you need to have an eye doctor look at you at that 6 to 9 months window after due date. If you look at babies that develop strabismus or misalignment and look at all the babies that are born light or with a low birth weight and compare them to term, there's a big difference in percentage of babies that have misalignment. And the higher the stage of ROP, the higher your risk of developing misalignment of the eyes. Again, the question that I sometimes get asked is, what about that visual field? Is it going to affect my child's ability to drive? So we do have data for that from the freezing treatment study of ROP done in the 1980s. These children were compared at the age of 10 years. At that time, we weren't actually 100% certain whether treating would actually prevent blindness. So we had a group that were in the control group that never got treatment, and we had the group that did get treatment with freezing treatment. 90% of those eyes that were studied were in zone 2. So remember, this is mostly talking about babies that have got vessels that have grown further into the eye. If you took all the eyes that had gone blind and looked at the eyes that either got better on their own or the eyes that had been frozen and got better and compared them, there was a difference in the field of vision peripherally. So like when you put your hands out and you can see, whilst you're looking ahead of you, you can see your hands either side. That area was reduced by about 5% in the babies that had treatment. So it is a change. It's not huge, but it may affect the ability of your child to drive, specifically if you have disease in zone 1, because more of the area of the back of the eye is affected. So I want to tell you a little bit about our experience. I've been responsible for infants being treated for ROP since 2004 in Sick Kids Hospital. And the success of our laser treatment has been fantastic. In fact, we looked at our data over 10 years between 2004 onwards, and we had greater than 95% success in preventing bad outcomes with retinal detachment, stage 4 and 5. Since 2011, we've also been offering injection as a treatment, and we have similar success rates to laser. So we do offer both to you as parents, and we talk about them, and we go through the pros and cons and let you decide. We do know that the result is that you'll be seeing us more often if you get an injection. You're much more likely to have lower myopia, and In fact, we've looked at binocular function, and we see that infants that got injection have a tendency towards better ability for the two eyes to work together. That's our follow-up data, so more visits if you're in the injection group compared to laser. What happens to effects on other organs? Well, we're really interested in what happens to the brain. The eye is actually part of the brain, and we're worried because some of this medication that we inject into the eye does get into the bloodstream. And we want to know whether it affects any other organs. So we actually looked with our colleagues at babies at the age of 18 to 24 months. And although these kids are extremely fragile and they are very sick if they need to have ROP treatment and their neurodevelopment is affected, no matter what treatment they get, we could not identify a significant difference between the babies that got injected versus the babies that had laser treatment. So that's encouraging, but there's more data that's needed in this area. So this is a list of some of the studies that we've done. I'm very grateful to all my collaborators to be able to do this work over the years. And I do implore you, if we approach you, to help us to do more studies on infants that have had treatment. And as your baby grows older, we can do more testing to be able to answer some of these questions better. So what our protocol is, if you've had treatment at our center, we'd like to see you, especially if you've had severe ROP that has needed treatment, or if you've had other diseases that affect the central nervous system or the brain. But babies that have had mild disease or no ROP or did not need treatment, we recommend that you have an eye exam at 6 to 9 months past your due date. And then if all's well, then once a year examination is sufficient at your local eye services. So my take-home messages for you are that ROP is largely preventable cause of blindness. We've shown that with our results. Anti-VEGF injections are particularly useful as an alternative, especially for treatment of disease if it's in zone 1. We do need more long-term data. And we've so far have had excellent experience in Toronto in collaboration with our neonatology colleagues and neonatology follow-up clinics and pediatrics. And we are doing ongoing studies on what's the best path forward in terms of treatment with anti-VEGF medications. And remember that your baby, if it was born premature, is especially in need of long-term follow-up for eye examinations, at least once a year, even if they've had mild disease, and maybe more frequent if they've had ROP that needed treatment. Thank you very much, and I'm happy to take questions.
Dr. Tehrani, thank you so much for your presentation. Always learn so much from you, and I think you explained so well for families to really understand. And we have a big audience of parents who had 22-week babies on our audience today. And we have someone joining us from South Africa. And we have a first question here from Laurie Romas. Thank you, Laurie, for joining us. Do brain bleeds increase the risk of eye problems or ROP?
So that's a really good question. It doesn't, the brain bleed itself doesn't cause the ROP. But we do know that babies that have bleeding in the brain are more likely to have severe ROP. It's like several other diseases as well, such as necrotizing enterocolitis or severe lung disease. These are associations. They don't cause, but if you have one of these, you're more likely to have the others. It's a sign of a sick baby.
Right. Dr. Tehrani, in terms of long-term follow-up with these babies, because you mentioned like the babies who did have treatments, they go to you to a specialized clinic and the other babies get follow-up in the communities. Do all optometrists or ophthalmologists that you see in the communities are aware of ROP and they know what they are looking for?
They are aware, but like everything else, some people have a special interest in the area and they have special aptitude to look at babies and to look at infants, and they're good at examining infants and babies. So we work with a very strong group of optometrists and ophthalmologists in our community. So when you leave us and we send you and say, look, you need to be seen in the community, we actually provide a list. So within Ontario, at least, we can do that for you.
Okay, so let's talk a little bit about your the telemedicine that you are trying to implement, or you have interest in, for more remote communities in Ontario. How would that work?
Oh, we actually have a program that has been working now. Oh, I've lost track. I think it's been 13, 14 years. It's been so long. And I think it's I believe it's the only telemedicine program for RRP that there is in Canada. I may be mistaken if they have other programs have started, but it's certainly the oldest one. And we have places such as Sault Ste. Marie, Sudbury, and Barrie. And we actually have another center in Grand River in Kitchener area. So these are places where they have either lost their ophthalmologists who were doing the eye screenings, or they just never had people who could do this. And they are using a fundus camera, a special camera that's used for taking pictures of premature infants. They take images, and we've helped train the neonatal nurses to take those images and then send them to us. And I read the images and I send back reports. So the babies don't have to get into airplanes or helicopters or ambulances and boats and get to sick kids, which is what they used to do when I first started.
Well, so you watch if the ROP is progressing, you maintain the screening, and then if the baby needs treatment, then they come to see kids for treatment.
That's right. Yes. Yeah.
That is wonderful. Okay, so we have a question here from Heather. Heather is Gage's mom, born at 22 weeks. She wants to thank you, Dr. Tehrani, for everything you did or you do for Gage. Her question: does having severe ROP increase the risk of any other eye conditions later in life? Well, that is a great question.
Yeah. So we do have data, again, from all the sort of long-term studies. We know that if you've had very severe ROP, you are at risk of developing retinal detachment, even if disease goes away. Now, it used to be much more frequent, and I think it's much more likely in the older days. The earlier you get to the disease, the earlier that you treat, and if you can prevent stage 4 and 5 to begin with initially, then your risk of retinal detachment is actually less. And so the aim is to not get to the point where you've developed any retinal detachment or any pull or traction on the retina. If you can do that, then your risk becomes much, much less.
Absolutely. Okay, Dr. Tehrani, thank you so much for joining us here live today. I'm so grateful that you took the time to really teach our parents about ROP, and more specifically, how can we continue to screening and monitoring our baby's eye development later in life. So thank you so much for being with us today.
It's my pleasure. I am very grateful for all the help that you've provided in helping our families with premature babies.
Thank you, Dr. Tehrani. And really do reach out to us for research, because our families do like to be engaged in research. So there is a big channel for you here.
Yes, absolutely. Thank you.
Thank you. And we'll continue our next guest speaker, Jessica Newman. Let me bring her into the studio. Here we go, Jessica. And Jessica Newman is the mother of William, who was born at 26 weeks, weighing a little bit over 1 pound. Having her son born prematurely and so ill has changed the course of her life. She's now a social work student and will be supporting and educating and advocating for people in vulnerable positions for her career. Jessica, you tell how her son's ROP developed and how his successful surgery was at the Hospital for Sick Children. Jessica, thank you so much for joining us here today.
Thank you so much for having me, Fabiana, and it's lovely to see Dr. Tehrani again. She actually is William's ophthalmologist as well.
It is great, because what a small world that you're doing this work and you bring Dr. Tehrani, who really care for our babies. So we've been seeing her for 10 years now. I know you're a little bit shorter time, but she's such an incredible physician, and we're so grateful to have her in the care of our babies. So Jessica, I'll let you present, and then we will address questions at the end of Jessica's and Gigi's presentation. So please do share your stories with us. Would love to hear from you.
Okay. So I titled this William's Journey with ROP, my experience as a parent. As a parent, I can't really speak on his experience. I can only speak for what my experience was with his diagnoses. Next slide, please. So my son William was born at 26 weeks and 5 days at Mount Sinai Hospital in March of 2018. I had been diagnosed with hypertension and preeclampsia 2 weeks before. We live in Peterborough, so heading to downtown Toronto, twice a week, and ultimately being there for 4 months while he was in the NICU was a huge, huge change for my partner and I. He was not expected to live, as his estimated weight was below the 500 grams weight of viability, which is a problematic word, but that's something we can talk about another time. Next slide, please. So he was born, the last slide is actually the first picture we have of him, just a couple hours after he was born. So he was born and weighed 490 grams, or 1 pound and 1 ounce. It was very stressful, to say the least. We were in complete shock. I was pumping every 3 hours, so I was incredibly fragile and underslept. When he was born, he surprised everyone by breathing on his own for about half an hour and then needed CPAP support after that. They were expecting resuscitation, and that wasn't necessary, thankfully. The next day, he had to be intubated for about 12 hours, but was able to get back on CPAP after that. Next slide, please. He was ventilated for a total of 3 times in the first few weeks, and months, I should say. 6 weeks, I guess, and the longest time being about 2 weeks. He was on CPAP for a total of about 3 months during our whole NICU stay, so that was primarily where his oxygen support was. And because his breathing support was so high for quite a long time, it was the most important concern in those early days. So the 3 factors that Dr. Tehrani mentioned, low birth weight, early gestational age, as well as oxygen support, all come into play in William's case and his later diagnoses. Next slide, please. It wasn't until he was about 30 weeks that we started even hearing about eye exams, because in the NICU, as some of you may know, you just have to live it moment by moment. You have to live day by day. And if you ask questions about what the future brings, you're not going to get a very satisfying answer. So it wasn't until about 30 weeks that we started hearing about eye exams. Our nurses reassured us that it would be about every 2 weeks, and most likely he wouldn't have any issues. And if he did, it would likely resolve on its own. Next slide, please. A number of our nurses leading up to the first eye exam warned me and my partner not to be there. They described it and said it was pretty traumatic for parents. Little did we know we would see more than William's fair share. I was there for, I think, the first one, and, realized what they were talking about. And after that, I was at, I ended up being at many others, but after the first one, I had to take a break. I said, no, I can't do that anymore. And my partner took over that role for me. New slide, please. I was there for a subsequent one when the eye doctor conducting the exam said, okay, we need to test every week now. And the nurse and I were absolutely shocked. The nurse actually said, you mean every 2 weeks, right? But unfortunately, no, she was starting to see retinopathy developing. Next slide, please. The next few weeks, my son is 4 now, so 2018, and the next few weeks were kind of a blur for me. I was still pumping every 3 hours, so I was pretty severely underslept. And when you have a critically ill baby, you are in crisis mode all the time. Your nervous system is constantly in fight or flight, and you don't really have a chance to breathe ever. So it honestly is difficult to look back through my memory because I've just blocked so much of it out. It was really stressful seeing him uncomfortable during the exams. And we had been in Toronto for so long at that point, more than 2 months, with every day being spent at the hospital. New slide, please. So shortly after that, one day while I was resting away from the hospital and my partner was there for his eye exam, he called and said, William's eyes are worse. He needs surgery. You need to come in right now. So I went in, and the doctors had arranged for an eye exam to be done by an ophthalmologist at Sick Kids later that afternoon. So transfer through the underground tunnel, which was a first for us. New slide, please. The transfer to and from Sick Kids took ages and ages, and there was lots of hurry up and wait. The eye doctor that we saw was not Dr. Tehrani and didn't have the best bedside manner, and it was not an easy time for my tender heart. The results of that exam were okay. They didn't feel that the surgery was immediately necessary, so we would go back to Sick Kids for another exam the following week. Next slide, please. When we went back, we heard about all the options for treatment because his eyes were indeed worse. And that was Dr. Tehrani, and she did feel that intervention was necessary that week. At that point, both of his eyes were at stage 3+. When they described the treatments, my partner and I were immediately drawn to the laser option. The fact that it had been around, in some form for decades and was proven to be effective, wasn't like they had that long-term research, was really important to us. The other deciding factor for us was the follow-up after intervention. We were only staying in Toronto as long as William was in the hospital, and we were anxious to bring our baby home back to Peterborough. The follow-up was not as intensive with the laser surgery as it was with the injection, the Avastin. A new slide, please. We decided on the laser surgery, and it was done later that week. Once we knew that the surgery was happening, I was honestly able to relax a little bit, which maybe seems strange, but when things were getting worse and worse and worse without knowing what the outcome was going to be, that was much more stressful for me. But once we knew, okay, this is what has to happen, because something that you never have in the NICU is, okay, this is exactly what's going to happen. You just don't have that. It doesn't exist. So once we knew that the surgery was going to happen, I thought, okay, he's going to have the surgery. I can relax. So we were warned pretty intensely that it was likely he would need to stay ventilated for at least a few days afterward, but he shocked everybody yet again by being able to be extubated very soon after surgery, and we were transferred back to Mount Sinai later that day. Huge relief. So this picture is of him, just a few hours after surgery. He still was coming out of anesthesia, and he was very dopey and quiet, which is not like him. Next slide, please. That night and the following day, he was not himself. He was much more calm and quiet than his usual boisterous self. So his eyes were also very swollen, which was pretty sad to see. And we kept having to remind the nurses that he just had eye surgery. So the blinds had to stay closed for quite a few days in his room. By the second or third day post-surgery, he was back to himself. New slide, please. So we had a follow-up at Sick Kids the following week and the week after, and all was well. By that point, William was off oxygen support and was feeding 100% orally, so we were able to be discharged home exactly 15 weeks after he was born. We had one visit at Sick Kids the following week, but after that, it was every 3 months moving forward. Then it was once a year. And after that first visit, after we were discharged, they no longer do the horrible tests in the same way. It's much less invasive to the baby, which is so much easier on the parents' hearts. Still, the visits back at Sick Kids have not been easy, to say the least. William and I in particular have a lot of trauma around medical professionals. And for me, seeing him being poked and prodded for multiple tests through multiple departments that we see at Sick Kids is not an easy thing. It takes a lot of planning and a lot of advocacy to make these visits as stress-free as possible. Next slide. We are actually due for a visit in which William will have to be put under anesthesia to have a full exam and likely have more photos taken of his eyes, which they did during his surgery as well. He is, he's 4, so he is able to, he's able and he's comfortable saying when he does and doesn't want things to happen to his body. So it makes it difficult to try to encourage him to and explain to him how necessary these tests are for the health of his eyes and ultimately his whole body. And next slide. So he doesn't wear glasses yet, and he is a thoughtful, inquisitive 4-year-old, and he is just the light of our life. And yeah, we're very, very lucky to have him with us still. Thank you.
Hi, Jessica. Wow, thank you so much. You brought tears to my eyes, because it is true that it's not only the eyes, it's not only the exams, but it's the anxiety, the PTSD that we have to go back into the hospital. Yes, you brought me so many memories, because I remember the first few weeks going back into the eye clinic at Sick Kids. My anxiety was through the roof. I didn't want to hear Dr. Tehrani say, oh, but the ROP is back. I always pray in the waiting room that would be fine. And so far, 10 years later, almost 10 years later, it's still fine. But I totally understand, and I'm glad that you brought this up, because families think they are alone when we have this anxiety of going back and we don't know what's going to happen during the exam. And I have a few hearts for you from other families. I'm trying to put on the stream here. Let's see. Kira sent you a big heart. Kira is a mom of a 22-weeker baby. Thank you, Kira, for joining us here. So, Jessica, we are going to go with Gigi's presentation now, but I will bring you back so you can have a session of Q&A at the end.
Okay. Thank you, Fabiana.
So, and our last speaker is Gigi Kuwanga. I'm sure I pronounced your name wrong, Gigi. Kuwanga Fernandez, who is an accredited professional coach and founder of Families Blossoming, a professional coaching company she started over 10 years ago, initially focusing on the NICU community, but since then has expanded to other areas. Gigi considers her most significant role as being the mother of 4 angel babies and a surviving twin born at 24 weeks, who is the teacher of one of her favorite life lessons. The heart sees what the eyes cannot, which she applies in her work. Gigi, the mother and forever student of her son, who is also legally blind due to severe ROP, will take us on a part of her family's journey, which started in the NICU and continues today. As a mom and strong advocate, she will share aspects of her family's ongoing personal experience with his retinal disease, especially its profound impact on her son. She will highlight some of the key lessons she hopes NICU professionals can learn to improve ROP awareness, identification, intervention, and family support, and ultimately provide a much more proactive response. Gigi is an optimist at heart and will share 3 key ways in which her family have approached her son's blindness in a positive, empowering, and forward-moving manner, in the hope that it can inspire and strengthen other families experiencing a similar journey. And I have the honor to have joined me here live from London, England, Gigi. Gigi, it's so great to have you here. I'm so happy that, we cannot meet in person as in the past, but I can have you here. Gigi, you're mute. You can unmute your microphone.
Yeah, that's the story of my life. I talk to myself all the time. So, thank you so much. I was trying to quickly send you the slides without animation, so
that's okay. I have your slides here, and I can move them for you. And then for all of you watching us live, please do send your comments, your questions, and we're going to have a period of Q&A at the end.
Okay, thank you. Your baby is blind. Deal with it. These were the words that came out of the mouth of the retinal consultant who had recently performed laser surgery on our son's eyes in the NICU. And the words were like a sucker punch in my stomach. How could 2 short sentences delivered in a rather blunt and not so nice fashion, I may add, caused such confusion and despair and shock and anger? Next slide, please. I really felt like I'd fallen into this gigantic black hole. Next slide. And this was the start of us as a family embarking on yet another long and unknown journey. This time, the journey's name was Retinopathy Prematurity, or ROP for short. Being born the size of my hand at 24 weeks, weighing 645 grams, and residing in the NICU 1 week shy of 6 months, the life of our surviving twin, our son, had taken us on many unknown and unfamiliar journeys. Journeys such as infant loss, necrotizing enterocolitis or NEC, brain bleeds, and many, many more. Journeys that we didn't ask to go on, and we were not expecting to go on. What parent would? The consultant left the room and left us both figuratively and emotionally in the dark. Next slide, please. If my son could never see my face, would he ever really know me? This was a question that really hung heavily over my head and in my heart for a while, but I was determined to not let it stop me. Next slide, please. As a proactive mom and a former senior healthcare professional, both in the US and the UK, I knew that information was power. So I started researching and looking at anything and everything I could find about ROP. I reached out to many ROP experts and physicians. I wish I'd known Dr. Tehrani then. I didn't. So at the time we were still living in the UK as well. And I reached out to the Royal College of Ophthalmologists, to the American Academy of Ophthalmology. And my questions to all of them were the same. What exactly is ROP? How can it be treated? And more importantly, how did it happen to my son? Barring one group who I'll mention in a second, I didn't get a lot of responses. And the few responses I did get, they didn't provide me with a lot of information nor hope. This latter question of how did it happen to our son was one that I also asked our son's consultants in the NICU. We had grown really close to them during our long stay there, and we respected and trusted them. But I was perplexed because ROP was something so casually mentioned and not really explained during our time in the NICU. The reply from our NICU consultants was both troubling and surprising. They had never seen an ROP case as severe as our son's, and they really didn't know that much about ROP. They left it up to the visiting consultant because he was the expert. And I guess this partly explains sort of why our hospital's NICU normal procedure was that all micropreemies had their eyes tested. In that case, it was weekly by the visiting retinal consultant. And our son was no exception. And every week he had his eyes tested using that dreaded speculum and some of the images that Dr. Tehrani showed. And every week we were told by this consultant that our son's eyes were fine, quote unquote. And when I asked during one of these checks, what exactly does fine mean? I was briefly told about the ROP stages and that our son was at stage 1. And there was absolutely nothing to worry about. Next slide, please. So I didn't worry about his eyes. Instead, I worried about his heart, his brain, his lungs, his stomach, his weight, his growth, all which had been impacted by his extreme prematurity. And even when a few weeks later, the consultant said his stages were hovering between a level 1 and 2, I still didn't worry because the consultant said the worst that could happen was he would be nearsighted and wear glasses. Well, I'm nearsighted and I wear glasses, so I was familiar with that. When we were called in one day and told that we had to sign papers for our son to be transferred to another hospital for laser surgery on his eyes, I was really concerned. But again, I was reassured, and we were told that although he was at stage 3 now, we didn't need to worry because of two key things. This consultant was an expert, was very good, and laser surgery typically worked. And within a few days, our son would be fine. So you can understand why the consultant's words hit us so hard and didn't make any sense, because we had been constantly reassured with this message that everything was fine until it wasn't. Next slide, please. Out of the many ROP specialists and organizations I reach out to, one ROP specialist consulting group in the US was a light in the midst of our darkness. They responded in a positive manner, and although they didn't offer us any guarantees, they did offer detailed information, support, and hope. The only caveat was they wanted to see him ASAP. The problem with this was that our son was still in a NICU in the UK, and we didn't have a discharge date in sight. But his NICU consultants were brilliant, and what they did, they acted like he was being discharged, and they sent all of the relevant information over to this consultant group in the States. So by the time our son was actually discharged over a month later, we were ready to make the journey across the Atlantic, and we did. We stayed in the States for several weeks, I think 7 or 8 weeks, I can't remember. And our son underwent 2 vitrectomies in both eyes and 1 lensectomy in his left eye only. During that initial, he's also had other different procedures as well. But during the initial stay, and actually for many, many years later, he experienced a number of complications from his ROP, including retinal hemorrhaging and significant eye pressure, to name a few. But every step of the way, this ROP specialist consultant and his team told us what was happening, shared with us what to expect, what could go wrong, what the outcomes were, etc., prior to, during, and after any procedure or operation. Like I said before, information is power. And for us, we had lost so much of that during our ROP journey so far, that by treating us as integral members of the team and giving us information, they gave us a little bit of our power back. And in addition, they also gave us loads of strategies and tools and things we could think about to play with him, functional play tools that we could do to kind of gently stimulate his functional and residual vision while he was recovering and afterwards. And this was invaluable. Next slide, please. Fast forward to the present. And our son is now 15 years old. I can't believe it. He's almost 16. He's legally blind. He's a white cane user, and he's a proficient Braille reader. And yes, to answer my earlier query, he knows me almost too well. His left retina ended up progressing to a stage 5, so the most severe ROP level, as you know, and it's completely detached. And his right eye went to a stage 4B, and he has about 40% roughly reattachment due to surgical interventions in that eye, but it's not a smooth reattachment, so it's kind of like hills and troughs, so he doesn't get the clear picture. He's on daily drops several times a day, but the world is not complete darkness for him, and although he doesn't see like a fully sighted person does, he has what's called ambulatory vision. As far as we can make out, and as much as he can tell us and explain to us, he can see lights, movement, some primary colors like reds, greens, yellows, and contrast. So if you have a black object on a white background, he can tell that something is there. But he can't see the complete image, so he doesn't see my whole face, which is probably a good thing for him. But he can see bits and pieces, so like a little bit of your ear, a little bit of your eye, etc. If you're really close to him on the right side, where he has most of his residual vision. He remains under the care of the same ROP specialist team in the States, as well as his glaucoma specialist here in the UK. He's in year 10 and studying for his GCSEs in a specialist secondary boarding school for young people who are blind and visually impaired. Next slide, please. His school follows the UK's national curriculum, and he's studying biology, chemistry, physics, maths, English, IT, but he especially loves languages. And he's studying French and Spanish, all in Braille, and is learning a little bit Japanese on the side. He teaches us every day way more than we will ever teach him. And hopefully by some of the pictures that I'm showing you now, one key lesson that he always teaches us is that you don't need sight to have vision. We rarely use the word can't in our family, but we rather ask, what is another way to do something? He's our absolute joy and our precious gift, despite his typical teenagery moods. But so although we have chosen to focus on what he has versus what he doesn't have throughout our ROP journey, and it continues to this day, and it will continue on for the future, we've had the opportunity to meet several families affected by ROP around the globe. And we've realized that some elements of our story are unfortunately not unique. 3 things adversely impacted our story and other family stories as well. And they are, next slide, please. Many NICU consultants don't know that much about ROP. The second thing we experienced was the ROP specialist pool is pretty small. Although there are a lot of ophthalmologists, there's an even smaller number of pediatric ophthalmologists and an even smaller number of pediatric ophthalmologists who know about ROP, and an even smaller percentage of those who actually know how to treat ROP successfully, like Dr. Tehrani. And the third thing we realized was poor or incomplete or incorrect information and resources adversely impacts care and outcomes. And I say this because upon reading our son's medical records months later after he was discharged, I learned that during one of those weeks that I was told that everything was quote unquote fine, the doctor, in that case, it was a resident that was working under that visiting consultant I mentioned earlier. He actually had not gotten a good look at our son's eyes, and he didn't, during that visit, have the right equipment to properly examine him. And it put in the notes that he will see him again the following week. But the following week was the laser surgery. And we also found out from reading his notes that our son had developed plus disease as a part of his ROP, which accelerated his retinal detachment. None of this was told to us. Next slide, please. I know that change is happening, as noted by the wonderful insights that Dr. Tehrani has shared. And a lot of research is still going on. A lot of things we know about ROP, a lot of things we still don't know, et cetera, et cetera. But I really would like to contribute to this change of improving ROP care and treatment globally for babies and parents, families experiencing it by suggesting 3 things with the clinical staff. The first is ROP awareness and education, and something like this, what you're doing, Fabiana and Canadian Premature Babies Foundation, is amazing because, I really would like it to be a part of neonatologist medical training, but also ongoing professional development, because as Dr. Tehrani has noted, there's so many research studies that's still going on, trying to uncover and trying to do a lot of things to treat babies with ROP. The second thing I would like to suggest is proactive prevention. And we all know prevention is better than a cure. So many things in our son's ROP journey, I feel now, were potentially preventable. And the third thing is transparent communication with families. I would much rather know what's going on, even if it's a very difficult thing, than to not know. Next slide, please. As parents of children living with ROP, we know, like the entire NICU journey, it can be a major roller coaster ride, and it lasts for years and years and years. Like I said, my son is 15, and we still come up with things that we that are connected to his premature start. Vision loss in particular impacts almost every aspect of a child's development. I think approximately, I've read somewhere, about 85% of what a child learns is through what they see. So their motor development is impacted by their vision. If they see a toy, they want to reach for it, they reach and grab it, and so they're moving their bodies, etc. If they don't see that toy, they don't move. And also, education systems we've experienced have a lot of difficulty understanding and supporting a child with vision loss, so particularly a child who's a brailless or has severe vision loss like our son, and who's a braille reader. Next slide, please. Despite these challenges, I want to share with you a few life lessons that we've learned along the way, and we are continuing to learn. I'm pretty sure we'll learn so much more that I really want to leave to encourage you as parents. Trust your gut. You know, hindsight is 2020. I think some things I was feeling a little uncomfortable during this initial ROP journey, but I wasn't sure, and I didn't trust myself enough to ask those hard questions. 2, educate yourself. Tap into and take advantage of anything you come across that may help your child, whether that's Braille lessons, learn about different technology and apps. There's so many out there. I actually just finished a Braille course, and I wrote a note to Alejandro in Braille, and he said, "That's a really good, mommy, but you need to keep practicing." So I have a long way to go. Sit on your hands. This is a tough one, but it's really about allowing your child to explore the world around them, and you to provide opportunities and narratives and descriptions for them to do that safely. Instill confidence, self-advocacy, resilience, and independence in your child, and not dependence. Use any resources and equipment that you can find, whether that's audio, books, tactile objects, audio description, Braille notes, large print, etc. Anything that's going to help them make sense of this fully sighted world. Treat your child as your child first and not the vision loss. And by this, we often say that Alejandro is our child. We don't call him our blind child or blind son. We say he's Alejandro who happens to have vision loss. The emphasis is on him as an individual, not on his vision loss. And lastly, and most importantly, have fun. Next slide. So from my family to yours, I just want to take a moment to thank Fabiana again and Canadian Premature Baby Foundation for giving me this opportunity to share a small part of our son's RP story and my perspective as a parent. And to all of you listening, thank you.
Wow, Gigi, how do I follow this? I had tears in my eyes. And I'm sure Jessica too, and Dr. Tehrani left you a message on the private chat. She had to leave.
Okay.
But she said, I would love to hear more about you, Gigi, and your wonderful son. You are an incredible, brave, and great advocate for all premature babies. You taught us all. And I couldn't say anything more because I know I truly admire your strength, your advocacy, and everything that you are and represent to our community. So it is emotional because we all lived through this, right? The three of us and so many people on our chats today, they lived through this. We have our NICU stories that connect us all. And I really want to share some of the comments here. Let me see if I can put here so I can collect myself. This is from Heather. Heather is a mom of Gage who was born at 22 weeks. Heather is also a fierce advocate for premature babies. Such an inspiring story, Gigi. My son is only 7 and he has partial detachment in both eyes. He has awesome vision and is a white cane user and braille reader as well. So thank you, Heather, for joining us here today. And I really feel our stories connect us all. And it's so important for us to talk about it, to share our stories, to really also encourage parents who are still on the journey. And to really work, I think our whole mission at CPBF is to work with clinicians and researchers to, especially the communication piece and the research piece, because those are life-changing for us.
Yeah.
As both of you talk about it. And I cannot tell on behalf of Jessica, but I can certainly say that I feel that I'm very privileged that Gabriel was at Mount Sinai Hospital, which is across the street from Sick Kids. So we had the treatment right away, screening right away, and follow up on our backyard. So, and I know not everybody is as privileged and like we were, Jessica and myself. But Gigi, I have a question for you because you talk about information and raise awareness and educate parents. How much is too much information while the parents are still in the ICU and you know the eye exams are being done, there is possibly a progression of the disease. So how much is too much?
That's a really good question. I think it really depends on the families. And it really goes back to, it's important for clinicians to have a relationship with families. And you will know how much is too much. Families are incredibly intelligent and incredibly smart, and they will let you know how much they can handle. And we were a family, I think partly because of my healthcare background. My background is neurology, and on both sides of the Atlantic, so I worked in both healthcare systems. And information is so important for me. I just need to know what's happening. And I think what was unfortunate in our case is that even when we were asking the questions, we were not getting the answers. And probably because Alejandro was so sick that they thought, I don't want to give too much. But I think if a parent is asking you, look, actually need to know this, I think you need to give it to them. If they say, actually, I don't really want to know, you need to respect that as well. So I think the level of information is relative depending on the situation. And for us to find out things about his ROP care months later because we saw his records, we shouldn't have found them out that late, because we probably could have pushed more.
Right.
Just
what is your take on it in terms of education?
It's it's not a black or white decision. Exactly as Gigi said, it's a give and take between, if the parents are asking for more, then you have to be able to provide more in a still compassionate way, right? And without what we experienced, at least, yeah, and I wasn't going to talk about it because it was incredibly traumatic. But when we went to Sick Kids the first time it wasn't actually the first time, but we were there for something else beforehand. But when we went for the first eye exam, the doctor, I was crying, standing in the corner while they were doing the eye exam, and the doctor had a student, and he said, "Oh, go ahead and have a look." Meanwhile, my baby was laying there screaming with his eyes held open by these metal pokey things. And I was crying in the corner, and he looked at me and he said, "Oh, it doesn't hurt them." And I almost lost my mind on him. Like, I almost screamed at him. I almost said, "Get out of here. Like, I don't want to see you anymore. I'm not going to talk to you anymore. Do not touch my son." So I'm trying to get back to that. But without that compassion piece, and without explaining, it's important that the student sees this because this is a specific case and this doesn't actually happen very often, I would have been so much more open to her looking and explaining it and talking about it. And yeah, with that, there was also not a lot of consent from us. There was not consent asked, if that was appropriate. And so I'm talking too much, but it goes back to consent and compassion. I think asking, would you like to hear more? Is this too much information right now? Can we revisit this? Something like that. Like, there has to be just clear, direct communication with compassion and consent, I think.
Absolutely. No, and it's very hard. And for us who have kids with disabilities, and we still go on the journey for many, many, many more years with the medical system. And here in Toronto, we have a lot of university hospitals. So the residents come, and it is very hard, right? Because as much as we want to provide support to them to learn from our children, it's also very impactful to us as families. And how do you get the balance of compassion while you still want them to be trained, because they will be the future doctors for the future generations. So that it is very hard for families, and a lot of our community of parents with kids with disabilities face that here.
Yeah, I love what Jess just said about the compassion and communication piece, and how they don't stand alone, that they go hand in hand. But I think one of the key elements to what you were saying, Fabiana, is making sure, that parents are they're part of the care team. They cannot be looked at as something else. And so they have to be brought in on decisions, on communications, on et cetera, because, as a clinician, I found out that, parents know your kids better than anyone. You may not know all the medical jargon or whatever that's being said, but that instinctive thing, and I think if the shift towards our NICU was a teaching hospital, but the shift from a family is a it's a diagnosis. So it's a preemie, it's a this, it's a that, versus this is, so-and-so that has this is their family, this is what they like, it's what they like to do. And I think the more we shift towards actually thinking about families as integral team members, and they are essential in the care of not just in the NICU, but post NICU and beyond, I think we'll be going in the right direction. That's my little soapbox, so I'll get off it right now.
No, but it's good. And I think it is what we always striving for as parent organizations worldwide, right? To see us as essential caregivers throughout the entire journey, not only the NICU. We're not visitors, right? We are the essential caregivers. We understand our children. So we still have a long ways to go, but I feel that we are moving to that direction. Like it's going to take years, take times for change, but I think we are moving in that direction. So I would like to both of you to give like some final thoughts for the parents who are listening to us today before you wrap it up. Today, this month is is Vision Awareness Month, and we are discussing ROP because of Vision Awareness Month, and is a condition that affects a lot of our preterm babies. So one last message from both of you with a lot of experience with ROP. Maybe Gigi, we'll start with you.
One message for parents. I think one of the things I was saying earlier was really listening to your child and really trust the fact that you know what's going on with them. And I think I found that a lot, not just in NICU days, but also his education days. It's incredibly important for you to be that advocate for your child. Maybe I said too many things, but I guess it's about listening to your child, knowing them, and then being the advocate for them.
Absolutely. Jessica, some final words from you.
I agree. Just being their advocate, being their support, being their number one when they need you to be is the biggest thing, I think, is, listening to them and making them a part of the decisions as well. Saying with my son with follow-up, I could go on and on, but with my son with a lot of his follow-up, we say like, how can we make this easier? What would make this easier for you? This is what has to happen. This is what we'd like to happen, and these are other things that we can do while we're in Toronto, while we're at Sick Kids, whatever. Making him a part of it is big.
Wow, that is great. So Gigi and Jessica, thank you so much for joining us here today. It was so great having both of you. Gigi, you from London, you're many hours ahead of us, and I'm so grateful that you took the time to share your story and your journey with us. Same with you, Jessica. Thank you so much for always engaging with CPBF, always replying to parents' questions on our private parent group. I'm very grateful to both of you.
Thank you. Thank you so much. And thank you to everyone. I can't respond, but I read some of the comments, and thank you so much for your amazing comments. They were very heartwarming.
Yes, both of you go back on the chat. There's a lot of great messages there for both of you. So thank you. And to all of you watching us live today on our YouTube channel, Facebook, or Twitter pages, thank you for joining us here today. And the video of today's session and all the videos from our live series are available on the CPBF website, which is the CanadianPreemies.org. And I want to thank our sponsor, AstraZeneca and NATOS, for their ongoing support to our education sessions. And we are a charitable organization, and we believe that through support and education, we can empower families, ensuring they are ready to care for their babies. Please visit our website, consider making a donation. Together, we can create a brighter future for all our families. And I will see you again next Friday, 1 p.m. Eastern Time. Thank you. Stay well.